Our next speaker is Dr. Lucas Giunta. Dr. Giunta attended medical school at Lake Erie College of Osteopathic Medicine before completing an anesthesiology residency training program at Thomas Jefferson in Philadelphia. Following residency training, he completed a critical care fellowship program at Vanderbilt University in Nashville, Tennessee, and later returned to Jefferson to complete cardiothoracic anesthesiology fellowship. He's now on staff at Jefferson in the role of cardiothoracic anesthesiologist and CVICU intensivist. He will be speaking on patient blood management recommendations as they pertain to perfusion interventions. Please join me in welcoming Dr. Giunta.
Thank you, Dr. Henson. Very excited to be here and very honored. All the people that are here, Dr. Henson and the two attendings there, were really instrumental in my training. So it's feel very honored to be able to speak with you guys on the same day, which is very, very cool. So what I'm as advertised, I'll be speaking on the review of the Society of Thoracic Surgeons, Society of Cardiac Anesthesia, American Society of Extracorporeal Technology, and Society for Advancement of Blood Management recommendations for patient blood management, but mostly emphasis on perfusion interventions. So when I say perfusion interventions, I mean as it relates to the cardiopulmonary bypass system. So when I had originally given this lecture to my department sometime after these recommendations came out, and it was very clear how sporadic our adoption of a lot of this stuff was. And I think it's probably pretty true of a lot of departments as far as utilizing some of these techniques. So when I heard some of the topics and what we're here to talk about, I thought this could be useful. Also, I remember when I was in training and I was a med student, and early on in my residency training when I was in the cardiac course, I remember some of these terms kind of getting thrown around, and I didn't know what they were. And I wish that someone would have just explained it. So yes, we're going to be talking about some guidelines here, but realistically, disguised in there is basically just the ability to kind of teach you guys a little bit about some of these terminologies so you don't feel so silly if someone were to bring them up to you. So I was really happy to see that there was a lot of students in the audience. Also, I'm well aware that not everyone here is a cardiothoracic anesthesiologist. This is important too, as all of us are going to be dealing with patients that have previously had cardiac surgery of some sort, may even had a long post-operative course for whatever reason. You might be seeing patients you might do ICU medicine and be seeing patients that are post-operative in that regard. And just having an understanding of what was being done from a resuscitation perspective, what were some of the things that the doctors were doing in the OR to help smooth out these patients' courses and stuff like that, I think it's going to be beneficial. And I'm biased, but some of this stuff is actually pretty cool. So my goals for the lecture is going to be describe the origin and evolution of the guidelines, emphasize the current recommendations as it regards to perfusion interventions, like I said. Most notably, I really want to talk about acute normovolemic hemodilution and retrograde autologous priming. We're going to talk a little bit about minimally invasive extracorporeal circulation, but that's a little bit more of a nebulous topic. There's some cool literature that I'll explain to you about it, but it's a little less relevant day to day. We'll review some of the relevant literature, like I said, and we'll provide insights into the future research needs and recommendations. So there's the paper. So what exactly is this recommendation? And it kind of just looks like a bunch of letters. So it's a collective effort of those four societies that I will not rename again because I don't want to waste your time. And then it was co-published in all of these really high-profile journals. So the goal was to improve and optimize patient blood management strategies for all of us. And so what they did is they did a systematic review of all the current literature and then came up with recommendations. So the recommendations that how they did it, they used the ACC and the AHA kind of rating recommendations for strength of recommendation, rated from 1 being really, really high strength of recommendation all the way down to 4, meaning they don't really recommend it. Then they looked at the literature, then they rated it A, B, C, or D. A being that it's a really, really strong grouping of literature, and then D all the way to just being expert opinion. So we'll go through that a little bit too. So why are we interested in it as cardiothoracic anesthesiologists? Well, it's perfusion techniques, so it's specific to this patient population. So cardiac surgery population, we're very interested in it. It potentially has an effect on morbidity and mortality. And if you're running a department, it's beneficial to know about this stuff too, even if you don't do cardiothoracic anesthesia, because these are metrics that are reported and tracked by the Anesthesia Quality Institute So it's directly related to your compensation from a quality metric perspective from CMS. And we all want to provide safe anesthetic care for our patients. So here's what the AQI has listed. Hold on, let me go back. Has listed as the things that they look for reimbursement. That second one is minimizing hemodilution. So the techniques that I'm going to be talking about today, if you utilize any of them, you're meeting that metric. So it's important to know. And like I was saying before, when I first went through this with my colleagues, it was clear that there was a very sporadic adoption of a lot of this stuff. So focus of this presentation, again, perfusion strategies. 3 things we're going to do: acute normovolemic hemodilution, retrograde autologous priming, and then a little bit about mini circuits and minimally invasive extracorporeal circulation. Okay, acute normovolemic hemodilution. Before I explain exactly what that is, let me just tell you what they say about it. So the recommendation is acute normovolemic hemodilution is a reasonable method to reduce bleeding and transfusion. And they say it's a class 2 strength of recommendation with a level A strength of or level of literature. So they're saying we're pretty sure this is a good idea, and the literature is really, really strong. It also shows that this is in the grand scheme of things, a reasonably new thing in the conversation of, or technique in the conversation of cardiothoracic anesthesia. It wasn't even mentioned in the 2011 iteration. It was because the literature really wasn't robust enough. And now we're in a situation where they're saying the literature is level A. So we've really had some changes over the last 10, 15 years. But we're currently, even with these recommendations, have limited widespread adoption. At the time of this publication coming out, which was maybe about 4 years ago, we had less than 17% usage of this in all of cardiac cases. So people really weren't using this at all. So what is ANH? So ANH is when, after a patient goes to sleep prior to cardiac surgery, what we'll do is we'll place a venous line, whether that be a central line or a large IV, whether it be a 14 gauge or a RIC line. And then prior to engaging in cardiopulmonary bypass, we will then remove patient's whole venous blood, and put it into citrated bags, store that for the entirety of the cardiopulmonary bypass pump run, and then give it back to the patient as whole blood. To replace what was removed from the patient, often it'll be replaced based on the patient's hemodynamic status with either crystalloid or albumin. And that sounds great in theory, and it is a lot of fun to do. And it has beneficial effects because you're not allowing the blood to contact the ECMO circuit, the bypass circuit, and you are having whole blood that you can then give back to a patient with its rich and pretty untouched red blood cells as well as clotting factors. But nobody does this the same way. So even at my own institution, everyone just kind of has figured out a way that works for them in their workflow for the day. They pull off whatever volume they think is reasonable for a patient. They choose when and when not to do it for a patient based on factors that they've kind of felt in their practice is reasonable enough. And there's not a whole lot to kind of guide the best ways to do this. And even in the literature, when they were reviewing it, there's holes in that as well. But I'll tell after this during the questions, if anyone is interested and wants to know, I'll tell you at least how I do it. So what are the things that most people do look at when they're trying to decide whether they're going to do this? Well, looking at the initial pre-op hemoglobin of the patient. If you have a high hemoglobin, then you have some hemoglobin to spare. If you have low hemoglobin, the concentration of red blood cells is low. Removing red blood cells is going to really be detrimental to the patient's oxygen carrying capacity, even if you are on a bypass machine. And then also, patient's initial total blood volume. Obviously, if the patient's unstable, you're not going to be doing this, but really what we mean here is just patient size. So if the patient's really small, even a small amount of blood can have a lot of hemodynamic consequence. And then intraoperative blood loss. As you'll learn, some of the students, when you're in the cardiac case, you like to think that all of the blood that is entering the field is being sucked up and then re-returning in some capacity back to the circuit. But you will find that you look over at the perfusionist and they'll say to you, we're losing volume. We're not getting everything back to the circuit. And sometimes you're losing it elsewhere, either on the floor, somewhere else in the patient, or whatever. But in that case, it's probably better not to give more crystalloid and dilute the patient, and probably just give the blood you took off back right directly to the circuit. All right, so what does the literature tell us? So I'm not going to belabor the literature, but I'll just show you, exactly what they're basing this off of. So this was published in Anesthesia and Analgesia in 2017. It was a pretty large meta-analysis of 29 studies with 2,400 patients. And what did they find? They found that A&H group received fewer total red blood cell transfusions in comparison to standard of care. They also found that less patients overall required any transfusions at all. 42% versus 56%, and then based on what they were able to gather from the literature, they actually had less blood loss altogether. So, what are the limitations? Well, the studies had varying degrees of heterogeneity, all different types of cardiac surgeries. Every institution has different cardiac protocols, and then, like I was saying, everyone does this a little bit differently. What's the technique that they use? They use a central line, they use a 14 gauge, how much volumes did they take off? What were their inclusion criteria for what they were going to do, and they were going to do it? Who did they? Were some institutions better at choosing patients that they're right for or not? Things of that nature. So we need more homogenized randomized controlled trials. But the safety profile for this is really good, and we have pretty clear evidence that it decreases the amount of red blood cell transfusions a patient is going to get. So I would say it's probably a pretty good idea for patients that have decent blood volume and normal size and have pretty high hemoglobin levels. All right, retrograde autologous priming. What does the recommendations recommend? So retrograde autologous priming of the cardiopulmonary bypass circuit should be used whenever possible. And they say it's a class 1 strength of recommendation, so they're really putting their nickel down on this. They say that we really should be doing this. Level B, which means that it's a high moderate level of strength of literature. So what is retrograde autologous priming? So just a quick refresher for some people, and maybe even an introduction to this. So cardiopulmonary bypass circuit, we place an arterial cannula. It goes into the ascending aorta, and then we place a venous drainage cannula that goes to the right atrial appendage. And then generally, there's variations, but generally goes down into the inferior vena cava and that drains the blood. The blood drains from the venous side, goes through our circuit, gets oxygenated, and then goes through the pump, and then comes back and returns to the arterial circulation versus into your arterial cannula. So blood usually flows out of your arterial cannula. Also, the cardiopulmonary bypass circuits are usually primed with crystalloid solution as to prevent any air from being re-injected into the patient, unnecessarily causing strokes and other things. So what we do with retrograde autologous priming is once we have our cannulas in place, we then allow blood to bleed back through that arterial cannula in the opposite direction from where it normally goes, displacing back that crystalloid using the patient's own blood to prime the circuit. I'll show you a diagram here. So this diagram is a little bit, it's intricate, so I'll try to explain it to you. So this will be your arterial cannula. This is the darkness of this image is the blood being fed retrograde, and then here's a collection bag for all of the unnecessary saline. They do it through portions of this tubing. This is just showing that they can redirect it through other portions of the tubing. And then another important part here is this is the patient's venous tubing. They also do what's called antegrade priming, that's why people say RAP and AP. Sometimes you'll hear. But the recommendations are just, in this case, are just for RAP. So the things affecting whether we can do RAP is hemodynamic stability. You're basically exsanguinating the patient. So you got to make sure that you have some vasoactive medications at the ready. But with that being said, it's very easy to manage patients' blood pressure in these cases. You have both cannulas in already. You've given your heparin, you're anticoagulated. The first sign of hemodynamic instability, you can just go on bypass. This is an incredibly safe technique for blood conservation. And I find the biggest issue with this is having a perfusionists that are proficient at doing it, and then also having surgeons that want to wait the 5 minutes to just let the blood displace out. I'm telling you, in real time, we'll have it. We will have the cannulas in. We've given heparin. We have the ACT we want, and then we'll be like, we talked about doing RAP, and they're like, no, just go on, and you're just like, God, and you just got to do it. But I think that's becoming less and less as people kind of know more about it. But what does the research show for this? So remember, they said this was a high moderate level of research. So it's a slightly smaller meta-analysis, 6 randomized controlled trials, 557 patients. And what did it show? So it showed that there was a 64% reduction in patients requiring red blood cell transfusions intra-op and 74 for the stay. This is like we can do a lot of good by doing this. And the number needed to treat for hospital stay is only 4. And it's so safe that, granted, it's a small sample size, and they only looked at CABG patients. So this is it's limited. I agree, but with the safety profile being so good, we should just be doing it, in my opinion. And we'll talk to we can talk about it if you guys feel differently or someone has something to say about it. But that's my opinion based on what I'm seeing here. Mini circuits and minimally invasive extracorporeal circulation. So this is a little less pertinent to our everyday. A lot of this stuff is a little bit cost prohibitive, and then also the evidence isn't necessarily strong enough for mortality benefit to warrant the change in the paradigm shift that would be required, changes in training and a full investment in some of this technology. But I just want you to know what it is, because it might be something that rears its head in the future, and then also some of it's kind of interesting. So what do they recommend? They say that you should be reducing blood priming volumes, which makes a little bit of sense, but I'll show you there's some issues with that as well. And then minimally invasive extracorporeal circulation is a reasonable thing to do to decrease red blood cell transfusion, and I'll explain what I mean by that. So what is a mini circuit? A mini circuit is what they're referring to as just smaller circuits, smaller pump volumes, and decreasing the amount of hemodilution the patient might be experiencing, and that's supposed to decrease the amount of red blood cell transfusions that you're going to need. But it doesn't really say how much you're supposed to take off, and if taking too much off is an issue. So I have an article here that was published in the Annals of Thoracic Surgery that is a little bit concerning for this. So what they did is this was a large observational study using patients from a registry that included CABG patients from a period of time. What they did was they normalized patients' pump volumes and created a ratio based they normalized the patient's pump volume to their blood volume, creating a ratio. They called that the PV ratio. Then they looked at how many people needed blood transfusions and how many people needed large amounts of blood transfusions. And what did they find? So don't worry about this middle part. I'll show that in a graph in a second. But the top part says transfusion patients had an average PV ratio of 20 compared to the non-transfused. So this is where we're getting a recommendation that we should have less pump volumes, because less transfused patients had less pump volumes. But PV ratio average was 0.15, was associated with the lowest probability risk of red blood cell transfusion, which increased transfusion rates demonstrated above and below this rate. So what that means is that we look at this graph here, and you look on. So what this is showing is patients that require the probability of a patient having any blood transfusion. And you can see that the pump volume is being very high. As you go up, you have increased possibility of blood transfusions. As you go down up to about 0.15 of that PV volume, you get low, but then as you get lower, you increase your rate of blood transfusions. So trying to find the perfect pump volume ratio for each patient would be extremely tedious, extremely difficult to do, and would also be require specialized circuits for almost every patient. So that would be I don't know if that's something that we're willing to do with the limited amount of research that we have. This is showing patients that require large volumes of transfusions, greater than 4 units. You can see that large pump volumes don't really have an effect on patients that get large transfusions, probably because patients that are bleeding a lot are bleeding a lot for other reasons. But you can see, even in this patient group, as you decrease the pump volume, they increase their probability of even getting large transfusions. It's pretty dramatic. Okay, so some of the things that the registry did lack was some potential address. They didn't address some of the potential confounding barriers, especially this one, transfusion triggers. So we really need to know more about this PV, this pump volume, and things like that, to really say that we're going to do this and invest in it. The other thing is, what is minimally invasive extracorporeal circulation? So this is something that was defined by this society, the minimally invasive extracorporeal Technology International Society, and they outline minimally invasive extracorporeal circulation as ECMO, bypass circuits that are utilizing things like tubing that is biocompatible with red blood cells, utilizing centrifugal pumps. I know you've probably seen that a lot when you're studying for anesthesia boards and things like that, versus roller pumps because it is less damage to red blood cells, things like that. But one thing that they also talk about in this is using a closed circuit versus an open container circuit. And I would say that almost all of us in our in the cardiothoracic or in the cardiac ORs will see open circuits in the United States, just because that is kind of the way that we do it here, the way that our perfusionists are trained, the way the surgeons feel comfortable. And the idea behind it was that having that open container for blood to go in has a really good safety profile as far as air is concerned. Minimally invasive circuits, by definition, are a closed circuit that just have an air extraction system. Honestly, I'm not an expert on them. I'm not entirely sure how that works, but that would be a huge investment and a huge amount of training and a huge amount of shift of thought for us to be able to do that. So the evidence better be pretty good. And here is one of the articles that they did reference, and it was a meta-analysis of circuit comparisons. One of them being the minimally invasive, and then obviously the conventional. And let me skip to what they found. They found that there was a decrease in the patients being transfused, and they did find that there was no real difference in safety profile, but there was no mortality benefit. So in order to really change everything that we're doing from a perfusion perspective, I think would take a little bit more than just some data on small minimization of red blood cell transfusions. So because there's no mortality benefit and there was significant level of heterogeneity to a lot of what that research shows, I don't think that's going to be something that's going to be have widespread adoption. Here's an example of this, like kind of the best image I could find. Again, like I was saying, I'm not a real expert in minimally invasive circuits. I just think they're kind of interesting because I don't know if anyone has experience with them or seen them before. But if you can see here, this is your venous cannula coming from the right atrial appendage and MVC, and it's going right into a venous bubble trap. It's not going into a canister like you'd see in the ORs that I've been in. So that's actually a component of minimally invasive extracorporeal circulation. But everything else we pretty much do as a standard now, I think, in most institutions, the centrifugal pumps, the biocompatible tubing, and all that kind of stuff. And that's my talk.